It seems hard to believe, but I have been a psychiatrist now for over 30 years. I know you're probably thinking, wow, he looks so young. And I thank you for that thought. The year I graduated medical school in 1988 was the year that Prozac was introduced into the US market. And there was a hope that there will be new medications and that are better tolerated and that might be more efficacious, and we are going to get better outcomes for our patients. And since then, there has been tremendous advance in our understanding of how the brain works, the neurobiology of mental disorders, and many medications have now been developed with different mechanisms of actions, and we have a range of choices that we didn't have when I was in training. But despite all these advances, I'm here to tell you that even though a lot of patients are taking psychiatric medications, the outcomes are not necessarily that much better. Did you know that in the United States, of people who are 12 years or older, more than 10% are taking a psychiatric medication? That's a lot of people. But the incidence of depression has not gone down. The disability due to mental disorders has not gone down. In fact, major depressive disorder, according to the WHO, is now the leading cause of loss of productive life years in Western countries. And the rates of suicide have not gone down. The rates of the other 9 of the top 10 causes of death have decreased over the last 20-30 years. But the rates of suicide have remained constant, or in fact have gone up a bit. So it makes us wonder, like, why is there this disconnect, between all these tremendous scientific advances, wonderful and exciting, but lack of proportionate benefit to our patients and improvement in long-term outcomes for our patients? Why? In being a psychiatrist for over 30 years, one of the things that became apparent to me is that when patients would get better on medication and then come back again when they are sick, in a huge proportion of cases, the reason was that they stopped taking the medication, or the patient was admitted to the hospital and discharged, but then readmitted, and we say, what happened? In a huge majority of the patients, the person stopped taking the medication. Did you know that of people who are started on an antidepressant, before the first 3 to 6 months, like the initial treatment is over, more than half of the people have already stopped taking the antidepressant. And of the people who should take the antidepressant long term, some proportion of people do need to do that in order to prevent future episodes. Over 80% of them don't take the medication in the long run. So in fact, I joke with my patients, sometimes trying to motivate them to stay on the medication. I say that if people took their medication long term, then I would be out of a job, and that's why I have job security. So the important thing that research has shown is that medications don't work in people who don't take them. Medications don't work in people who don't take them. Maybe they should teach that in medical school. I don't think that I was ever told this in medical school. So it makes me think, like, why do they stop? Given that these medicines have such good preventive effects, one would think that people would stay on their medication. And there are, for any complex question, there are many different reasons for these behaviors. But the biggest single reason is side effects. These medications are not happiness in a bottle where you just take the medication and what you get is the benefits and not the side effects. The advertisements might show, it's somewhat amusing, a happy woman running through the fields, or like a happy family because the one member of the family had a problem and then took such and such medication and they are so happy now. But in contrast to the rosy picture presented sometimes by advertisements, medicines also come with side effects. When the person starts the medication, maybe they could have nausea or vomiting, or blurred vision, headache, tremors, or dizziness. Tremors is actually one of the leading causes of people with bipolar disorder stopping their medication long term because it's socially embarrassing. One of the things I realized is that side effects that are socially embarrassing are much more likely to lead to the person stopping their medication. Or in the long term, like if the person stays on the medication, other things that become very bothersome in the long run could be sexual dysfunction due to antidepressants, or weight gain that can be pretty bad with some medications, especially what are called the atypical antipsychotics. Unfortunately, it has become apparent to me, and that is the goal of my talk today, is to convey to you that side effects have been neglected by doctors, by researchers, and by medical educators, considering how important they are, as I pointed out. Many times doctors are reluctant to ask the patient about side effects because they believe that if you ask the person about side effects, they're just going to report more side effects. And there is some truth in this. They do. But it is also true, research has shown, that when the doctor is willing to talk to the person about side effects actively and proactively, then the chances of the person stopping the antidepressant goes down by half. So there is a benefit to discussing side effects. The other thing that has been found is that doctors tend to underestimate the importance of side effects, in the sense that they think that their patients have few side effects, that they are uncommon, and that they are not very bothersome. There was a big study done in California where they spoke to a lot of doctors and a lot of their patients, and they found that the doctors tended to think that the patient had only few side effects and that these side effects were not very bothersome. But the patients of these doctors said that they had several side effects and that several of them were quite bothersome to them. More than half of the patients thought that they had 3 or more side effects from the antidepressant that they considered to be quite bothersome. So there is a communication gap in some way. And lastly, the doctors tended to not manage the side effect. If a medication is very helpful and we think that this medication is the right medication for this patient, it's not always the right decision to stop the medication, which is what usually happens, or switch the person to another medication. But sometimes the appropriate thing is to manage the side effect until it subsides, so that the person can stay on this medication long term. My team decided that let's look at the research being done on psychiatric medications to see why is there not enough information about side effects and how to manage them. And we found that out of all the published studies done on antidepressants, the great majority, more than 80%, used no questionnaire or method to determine what symptoms the person had that could be side effects, and used no method to say whether these symptoms were side effects or not, other than comparing the rate to placebo. The other information that was lacking in these research reports was they didn't mention how severe the side effects were, unless the person was hospitalized or died, which is required by the FDA. But otherwise information was not provided whether the side effect was mild or severe. Did it last for a few days or did it persist for some time? And most importantly, what, if anything, helps to reduce the incidence of the side effect? It would be good to have all this information, right? Many years ago, a colleague of mine asked me, he said, I have a patient who's doing really well on an antidepressant. He had severe depression with suicide attempts and so on, and the antidepressant has worked very well for him, but he has this problem of excessive sweating. It's very bothersome. He has to change his shirt many times during the day. He doesn't want to go out to a restaurant because sweat is dripping from his forehead. Raj, you're an expert on psychiatric medications. What do you think we should do? I don't know. And I found that even though antidepressants had been available for 60 years, and this side effect occurs in somewhere between 7 to 14% of people who take an antidepressant, it tends to persist and can be very bothersome. But nobody had ever done a study on the treatment of this side effect. And this is true for a lot of the side effects of psychiatric medications, that the amount of research is relatively limited in terms of what can be done to reduce these side effects. I did subsequently do research and published a case report also of like different ways of treating this side effect. So we were in a state of shock. It was hard to believe how little was being done to assess side effects. So much was being done to have various questionnaires and so on to determine all the benefits that the person gets from the medication, and then very little in terms of side effects. What the researchers were relying upon is called spontaneously reported adverse events. Spontaneously reported adverse events means that when the research subject comes in, they would ask, how are you doing, any problems, and only if the person spontaneously reported that they had this or that side effect was it noted down. They were not specifically asked. And my biggest proof of why this is not adequate is that when the SSRI antidepressants were initially introduced, it was reported in the literature that there was an incidence of 4% for sexual dysfunction due to the SSRIs. And then subsequently, when specific questionnaires were done before and after starting the medication, we found out that the incidence of sexual dysfunction is maybe more like 25 to 30%. So a big difference between spontaneous report and specifically assessing the patient. So my point in this talk is that researchers, doctors, and medical educators have hugely neglected side effects in comparison to their importance in getting good outcomes for our patients. But you know who really cares about side effects? Who thinks that side effects are a really big deal is the patient. So this is not really a TED talk, it's a call to action. Our patients are not doing very well. We are not able to achieve good outcomes in the long run that should have been possible given the scientific advances, because we have not addressed the elephant in the room, which is the problem of side effects leading to non-adherence to the medication. So we need to all work together, researchers, doctors, patients, medical educators, policymakers, people who fund the research. They need to all address these issues. We need more research on how to evaluate side effects, how to counsel people about side effects, how to manage each of the side effects that are possible. So when I talk to patients, what doctors can do also is I try to tell them, listen, I will always spend a few minutes talking to you about side effects and asking you, and I want you to tell me about your concerns. But there are two types of side effects. There are nuisance side effects, like headache or tremor or diarrhea and so on, that are very bothersome, and we are going to do something about them. We are not going to ignore them. But at least they are different from these medically serious side effects which harm any organ of the body. So it's somewhat reassuring to know that at least they are not medically harmful. The other thing is that these nuisance side effects, they tend to occur early on. The great majority of them occur in the first 30 days and then they subside. So if I can support you by doing different things, I can support you by reducing this side effect, giving you some kind of intervention to reduce this side effect, and I can get you through the first 30 days, then it's quite possible that in the long haul you will be able to stay on the medication and derive the benefits. It's a real tragedy that people tend to stop the medication within the first couple of weeks, when if they had only been supported to get through the first 30 days, a lot of those side effects would have subsided. So I have compiled, and doctors need to be educated about, for each side effect there can be a menu of options, not just one thing that can be done, but a whole range of things depending on how important it is for the person to stay on this particular medication. There are many different strategies that could be done. I was never taught anything in medical school or residency training about how to assess for side effects, how to talk to patients about side effects, what to counsel them, or how to manage the different side effects. And this needs to change. Medical educators need to make sure that medical students and residents and fellows at least have some education about how to assess and manage side effects, so that we can they can have better outcomes for their patients. So this is like a missing piece, the neglected side of suffering, that I am urging all the stakeholders to come together so to complete this. And as this puzzle is completed, I believe that we can get better outcomes for our patients if we are able to empathize with their concerns, manage their side effects, reduce them, and help them to stay on their medications long term. We can get the outcomes that the psychopharmacology revolution has promised. Thank you so much for listening.